Okay, yes, so we look today particularly on the complications of pre-eclampsia, and we had mentioned that complications of pre-eclampsia can be maternal or fetal. And under maternal, we had general complications which apply to all populations, which mostly are cardiovascular in nature, and we also had specific complications which are to do with the placenta. We then narrowed down the general complications as cerebrovascular accidents, which can be ischemic or hemorrhagic. And I hope we all remember that the drug of choice in hemorrhagic CVA is the nimodipine. Not nifedipine, but nimodipine. Very important drug which we should have in our emergency units. Then, of course, we can have hypertensive encephalopathy. We did talk about the issues to do with the hypertensive retinopathy with its various grades. We went down to hypertensive heart disease and concluded by looking at acute kidney injury. So those are general problems. And if you remember very well, we mentioned that use of antihypertensive drugs reduces that risk. However, there is another class of complications which will follow the mother, which have nothing to do with cardiovascular system, but it will be with regards to the pathogenesis of the condition. And which are those? We did talk about eclampsia, we talked about cerebral edema, pulmonary edema, we went down to HELP syndrome, DIC, liver capsular rupture, liver failure, and we concluded by looking at the placental abruption, and also AKI by another independent pathway. So having said that, we looked at the fetal complications, which basically are three: intrauterine growth restriction, which usually is the asymmetric type, because the problem starts after 20 weeks, meaning there's head sparing, meaning that if you look at the biparietal diameter and the head circumference and the femur length, they will all be giving you almost the same weeks. So they will be talking about 32 weeks, 4 days, 32 weeks, 3 days. The other one will be maybe 31 weeks, 6 days. Almost close to 32. They are correlating. But if you look at the abdominal circumference, whatever centimeters it will give you by that Hadlock formula, after you freeze the image on the ultrasound, will give you something like 24 weeks. Why is the abdominal circumference being an outlier? Why is it so low compared to the other 3 parameters on ultrasound? It means that the fetus has been trying to compensate by getting to digest this glycogen so that it makes some sugar, some food to take to the brain and the adrenals. And that's why you find that the abdomen becomes smaller and smaller, whereas those other structures will appear as if they are growing normally because there's some compensatory mechanism. And that's how we interpret the biometry on the ultrasound scan. We are not really interested in the centimeters, we are interested in the weeks. Then, another thing that you see, obviously, if those processes are active in the fetus, what will then happen? The baby will be like one which is in shock. So what will it do? It will activate pathways. Remember, there were some, what we call autoregulatory pathways in the kidney. I don't want to go into the juxtaglomerular apparatus. We had the arterial, the afferent and deferent arterial behaving at their own level. We had certain transport mechanisms in the kidneys, particularly in the distal convoluted tubule, where you have those cells, the principal cells, that will be able to make some sodium-potassium exchange, and the role of aldosterone in all this. And then don't forget the role of antidiuretic hormone. It will kick in, at the space, particularly on the collecting ducts and the aquaporin 2 channels, right? And then in all this again, the sympathetics will come in, because when you activate the sympathetics, overriding the parasympathetics, what will happen? Okay, in all this funny equation, there will be retention. So urine output will go down. And if urine output in a fetus goes down because of the stress that you are giving it, what will happen? They will be reduced liquor volume. No wonder liquor volume or amniotic fluid index is a component of the biophysical profile. It helps us assess the fetal well-being. Okay, because if one is not losing that liquor by draining through premature rupture of membranes, why should the amniotic fluid reduce? It means the baby is holding on to its urine. Why is the baby holding on to its urine? It means it's being stressed. It's being stressed by what? By pre-eclampsia. So, looking at the biometry figures and the liquor volume and the entire biophysical profile of Manning, together with other parameters like the Doppler wave studies of the umbilical artery, looking at the peak systolic diastolic flow, I think it's a lecture for another day. Looking at the pulsatility index and the resistivity index, you can be able to tell that this fetus is being stressed, and you can make decisions timely. Now, IUGR was one of the fetal conditions. The other one is fetal distress, which I'm just from talking about. And the last one, obviously, is IUFD. Okay, now let me very, very quickly, in a few minutes, talk about just the important complications. I'll start with eclampsia. Eclampsia, we all know what it is by definition. It is the same pre-eclampsia, but complicated by convulsions. So it's convulsions in the context of background of pre-eclampsia. Then, the second question we have is, how do you make the diagnosis of eclampsia? It's a clinical diagnosis. Do you really need an EEG for that? No. You can put one and one together and be able to tell that this is eclampsia. Next, we ask ourselves, what investigations should we do in eclampsia? It's basically the same as where we are coming from. Full blood count, U&Ds, creatinine, LFTs, as you would call them, LDH, bedside clotting time, and of course the fetal parameters, which include what I've just been talking about. Ultrasound, which should include the biophysical profile, meaning you include it with the non-stress test, and also include your Doppler waves. Now, there's something extra you need to add in eclampsia in terms of investigations. Which are those? On the mother's side, you need to rule out other causes of fits. What are the common causes of fits? One is hypoglycemia. So we need to have a random blood sugar. Number two is what? Electrolyte imbalance. Do you know that if you have changes in magnesium levels, for instance, you can convulse? So you can collect blood for ABGs in a heparin bottle. 3, what else can cause a convulsion? Malaria, RDT, MPS. What else? Head injury. Because sometimes somebody could have convulsed and fallen down. You don't know which caused which. Is it the convulsion which caused the fall, or is the fall which caused the convulsion? So you might need to consider maybe a CT or just a skull X-ray. What else can cause a convulsion? It could be epilepsy, which has coincided with pregnancy. Probably you can do an EEG and look at the different waves there. What is the point we are trying to state? We are trying to state that we need to widen your differentials. A good clinician, a good nurse or midwife always thinks wide. What if it's not this? What else can it be? Imagine somebody has got epilepsy and we are treating as meningitis. Somebody has got meningitis, we are giving antimalarials. We are just going in different directions with the condition. That condition will take its natural course, and we know the inevitable that will happen to the patient. So a good clinician takes a good history, a good examination, formulates a diagnosis and differentials, and then manages the patient appropriately. Okay, now let's conclude with the treatments. What do we use to treat eclampsia? It's what we all know. It's magnesium sulfate. The same way we give it in severe pre-eclampsia is the same way we give it in eclampsia. Exactly the same. Now, what is special about magnesium sulfate administration in eclampsia? Magnesium sulfate in eclampsia has got an end point. Whereas in severe pre-eclampsia, there is no defined end point as to when you stop the magnesium sulfate. I know we always talk about 6 doses, then you say we have completed. We would say that 6 doses is adequate. Is sufficient, or it's too little? Do we have studies to that effect? So as you go maybe at postgraduate level, we are going to look at what we consider when we are looking at these studies. In fact, even in your own time, you can look at what's called the MAGPIE trial or the MAGPIE study, because that was really the genesis of the usage of magnesium sulfate. Just like that aspirin I was talking about, we have what's called the CLASP study. CLASP study, like you're clasping something. Okay, so there are a lot of other studies we use that helps us give evidence to certain guidelines that we use. Now, let me go back to eclampsia. Now, eclampsia, what do I mean by the end point? We say that you give 6 doses of magnesium sulfate after the loading dose, following a convulsion or a delivery, whichever occurs last. Following a delivery or a convulsion, whichever occurs last. What that means is that if a woman is 36 weeks gestation, not in labor, not in preterm labor of course, and then develops eclampsia, who starts convulsing, what do people do? They will quickly give a magnesium sulfate. They will load the patient, and then after they load the patient, they will start giving magnesium sulfate maintenance, not so. What will you do naturally? You might consider to say, okay, the Bishop score is good, it's 8/10, so let's just give 1-2 doses of misoprostol and deliver her within 12 hours. So maybe by the time she delivers, you would have given maybe 3 doses of maintenance magnesium sulfate, just as an example. Immediately she delivers, you ignore all the magnesium sulfate you gave. From deliver, you start counting 1. First maintenance, second maintenance, third up to 6. Because the last event is delivered, not the convulsion. Clear? Now, flip side. Somebody has delivered a baby, they are even celebrating with a baby. Then, what do you find? You find that that mother even goes home and then convulses, for instance. Okay, the delivery has happened first, the convulsion comes later. You, even if, let's say that patient had severe pre-eclampsia and received some magnesium sulfate previously, all that you ignore. Because you will look at the final event, which is the fit. And from that fit, you count 6. Clear? I hope it's clear. Yes. So that is the end points for eclampsia. In conclusion, going by the pre-charge regime, which we all use in our facilities, the repeat fit, you've started magnesium sulfate, you've given 2 doses of maintenance, and before you give the 3rd one, patient convulses. What are you going to do? You are going to repeat the loading dose, but you won't give 14 grams. Remember how 14 grams comes about? It's 4 gram IV, then 5 plus 5, which makes it 14. Those 5s are IM. But in this case, you get 2 grams of IV magnesium sulfate and load the patient. So you have the dose of magnesium sulfate. And that fit again becomes as if it's an event, not so? So start counting again, up to 6. So basically, that is it about magnesium sulfate. The rest of the notes are clearly outlined in your notes. I don't need to go through. But I have to mention here that before you even give, okay, let me talk about initial resuscitation. Somebody is convulsing. We know what is more important, not so. It's the airway, breathing, and ABC, whatever you do, you people, similar to what you call primary survey, secondary survey. Remember in general surgery, I always like that model of assessment. Now, what is the nursing care in eclampsia? It's exactly the same. Remember, where we are coming from, we said on the mother we monitor the BP, we monitor this and that, vitals, this and that. We have to monitor everything the way we monitor a patient. Now, what extra monitoring do you add in eclampsia? It's the fit chart. A fit chart is a very serious chart. You should put convulsion, you write there. Type of convulsion, tonic clonic. Duration of convulsion, 1 minute. what intervention was done? Maybe this was given, right? We don't use diazepam. Okay, but can use diazepam, 10 milligrams. Given by who? Dr. NPL, my consultant. The nurse should have a fit chart. Okay, the time the convulsion happened, the nature, duration, and so on and so forth. So that one is very important addition to the nurses. The other addition which is important is the GCS chart, because we know that when somebody is from having a convulsion, they will go into post-ictal phase. So they will be confused, they don't know what is happening to them. So it's important for somebody to monitor the Glasgow Coma scale so that we know whether the patient has become fully conscious or not. Clear? So, or the others like input, output, monitoring blood pressure, SpO2, temperature, respirations, those are well known. We know that those are addition. Of course, for the fetus, we have to do a continuous electronic fetal monitoring, meaning CTG, checking the peanuts more continuously, and everything else that goes with the monitoring the baby. Clear? Obviously, additionally, the nurse has to nurse the patient on a railed bed, or if you don't have a railed bed, you can put the patient on the floor. Not really the best, but a railed bed is more standard, so that that patient doesn't fall off the bed. Because that would even be a bad thing. You have eclampsia, or even have a danger on top of that. Yeah. Let me talk about the role of diazepam. Not really documented. We know that magnesium sulfate is what stops the convulsions, but I've personally used diazepam only in one case, not necessarily to abort the fits, but to manage the post-ictal phase. Because most of you have seen an eclamptic patient after convulsions are very aggressive. You'll be fighting with them, you know, because they have got a lot of energy, they're in post-ictal phase. So if you give them a benzodiazepine, you find that they will have rested, and by the time that drug is wearing off, the post-ictal phase would have ended as well. So instead of you fighting, and you find this one has tied the patient with the... No, tying a patient is not really the best thing, but you might need to use some medication to control that. Finally, there is what is called status eclampticus, which is similar to status epilepticus. I'm not a physician, bear with me. Where there is no regaining of consciousness between the convulsions, and that can happen in eclampsia. And if that is happening where somebody is just convulsing continuous, what are you going to do? Obviously, we need to include other medications also. And we've seen that commonly we go for phenobarbital infusion. But phenobarbital infusion has got a loading and a maintenance as well, and it has to be given cautiously. You are even better off giving phenobarbital near a ventilatory machine, either in HDU or in ICU. The other thing about the other drugs, should phenobarbital fail, what are you going to do? Now you might be forced to go for anesthetic agents, and that's where you can consult a critical care doctor like Dr. N. He's a critical care doctor. Anesthesiologist. They will come, you know, those put the long coats, not like this one, stethoscope. They put it around like this. You don't talk to people with round glasses. So those, when they come, they can now decide, no, let us use propofol, let's use thiopentol, and all that. Or what they can do is what is called induced paralysis. They paralyze you because they've got muscle relaxants. Don't forget that they've got pancreatic matacuria. They can stop those fits if they so wish, but they can use the machine to breathe on your behalf. No wonder I'm scared of anesthesiologists, because they can manipulate your physiology in whichever way they want. Okay, so away from eclampsia, I'll quickly narrow down on cerebral edema. How do you make a diagnosis of cerebral edema? So we are talking about cerebral edema. So in cerebral edema, we know that there is fluid accumulation in the brain, particularly in the parenchyma. And what causes this cerebral edema is the same processes that I was talking about. There is vasoconstriction, endothelial dysfunction, and fluid extravasation. what then will happen to the patient? Number one, in terms of diagnosis, it can be clinical or radiological. Clinical in the sense that you find a patient having a worsening gastrocoma scale drop. Dr. James Mulenga saw with him 2 eyes that patient where, I think even Dr. Tem, I can't remember who, but we had a patient whose GCS is dropping from 13 to 11 to 6 to 4 within a short period. So what you will start seeing first will be a patient who you are talking to. Next, they stop talking. Next, they only open the eyes to verbal. Next, they can no longer open the eyes to verbal. You see? So it takes you to have a high index of suspicion to say, this patient's GCS is going down. Now, the GCS is not explained by the postictal phase because the patient last convulsed 8 hours ago. I don't think it's postictal. Then it's not also being explained by what most midwives sometimes think magnesium sulfate. It's the magnesium sulfate which has made the patient to sleep and become drowsy. Are you sure magnesium sulfate really affects the conscious level? It can cause respiratory depression, it can go for the heart, but it will rarely go for the brain. So don't be so comfortable to say this drowsiness is just because of magnesium sulfate. Okay, and so on and so forth. So just have a high index of suspicion. Say pre-eclampsia, and then someone's GCS is low and it's getting even lower, then suspect cerebral edema. Okay, I forgot to mention last time that the antidote for magnesium sulfate toxicity is calcium gluconate. It's a rule of 10. 10, 10, 10. 10 meals, 10%, 10 minutes. Meaning you give it slowly. How does calcium gluconate work? We need to remember the action potentials. Remember the genesis of the resting membrane potential, the next equation, the equilibrium potentials. Now, if you remember on the heart, the cardiac muscle, we have a plateau phase. So what will happen is that the calcium gluconate goes to protect the heart. Almost similar to what we use calcium gluconate in hyperkalemia for. It protects the heart while you deal with the problem elsewhere. So that is about magnesium sulfate. Now, back to the diagnosis of cerebral edema. The other option is to do a CT scan. So you can do a CT scan with or without contrast. Still, you can be able to tell that this is a lot of cerebral edema. But really, is it necessary? If you are so sure that this is cerebral edema, it's better you even start managing it. Unless there is failed response to management, that's when maybe you can resort to CT. Okay, in terms of treatment, how do we manage cerebral edema? We use a drug called mannitol. Mannitol is a diuretic which we give at a dose of 20 grams, but you can give it as BD or TDS IV, depending on the response. So you can be titrating more to response. If you think the response is good, you can drop the frequency from 8 hourly to 12 hourly, and so on and so forth. Or the other option you have is to use a drug called acetazolamide, which, if you remember, is a carbonic anhydrase inhibitor. But really, the best, in my opinion, is mannitol. And the best combination is to give mannitol and a loop diuretic like furosemide, a low dose. Why? It's because mannitol will draw the fluid away from the brain, parenchyma, and then the furosemide will eject it from the vascular system. Okay, so I think all those notes have been put. What else should we do in terms of nursing care? Obviously, there will be monitoring of GCS. There might be a fit chart as well, because sometimes worst case scenario of cerebral edema can cause a convulsion. Then what else do you need to do? You nurse at 30 degrees head tilt, so that the head is slightly put upwards, so that there will be increased venous return through the jugular network and so on. Then what else should we do? We will monitor everything that we talked about. to do with the ICU care, because most likely you manage this patient from intensive care. So when you look at standard nursing care in ICU, I think the nurses know what it means. Now, why else should you look for? In your gist of vitals, it is what is called the Cushing's reflex. Because if we remember the Kelly-Monroe doctrine, it tells us that in the brain there are three things. There is CSF, there is the brain tissue, and what else? There is the blood. And then we have got a fixed cranium, which is a bone. The bone doesn't move. But these three components can change volumes. So, if you are going to squeeze the blood vessel because there is fluid, what will happen? Okay, I don't want to go into physiology, but it has a lot to do with the behavior of the chemoreceptors at the carotid sinuses and what they will do to respiration. So you find that the respiration can become irregular. You've seen what happens in head injury? Patient has the chain stocks and all those funny types of breathing. At the same time, what will happen? The pulse will drop, whereas the BP will rise. Have you seen that type of, the opposite of shock? The BP rising, the pulse dropping, the breathing becoming irregular. And that is called the Cushing's reflex. So you can be very particular. You as a medical officer, when you are passing through to review the patient, you'll be looking at the correlates of the BP and the pulse. Okay. Away from cerebral edema, we now go to, I think that's all. Oh, I'll conclude with pulmonary edema. So in pulmonary edema, we all know there are two types of pulmonary edemas. There is the cardiogenic and non-cardiogenic pulmonary edemas. Now, the one we have in pre-eclampsia is a cardiogenic type of pulmonary edema. So what is the diagnosis? You find that the patient will have an acute cough. Acute. So don't think of tuberculosis all the time when somebody is coughing. No wonder I'm scared of going to the one sometimes. It can be cracked and diagnosed as extrapulmonary tuberculosis. So what you're supposed to do is you find the patient was okay and then they start coughing. So for me, whenever I hear a severe preeclamptic patient starts coughing, I take it very seriously. Because what are you going to find? Pink frothy sputum. When they cough, they show you what they are coughing. They will be pinkish and with like saliva in it, with bubbles. No wonder it's called pink froth. Don't confuse it with hemoptysis. The other thing that you will find is that there will be difficulties in breathing. So there will be difficulties in breathing. Patient starts to breathe fast. So they become a bit restless. And then when you examine them, you find that the saturations are dropping at room air. They're in respiratory distress, meaning there's tachypnea, there is the use of accessory muscles of respirations and everything that goes with respiratory distress. What else? You find that the patient becomes restless or anxious. Then when you put the stethoscope posteriorly there, you find bilateral basal crackles or crepitations. So you can make a diagnosis, say this could be pulmonary edema. More so if the patient has acute kidney injury, because we know that AKI, one of the complications is pulmonary edema. So it will be like compounding the problem. Worse still, if you give so much fluids, again, that compounds the problem. So you need to think about pulmonary edema. What is the investigations in pulmonary edema? A chest X-ray suffices, but sometimes if you are so convinced that this is pulmonary edema, there's no need to even waste patient's time. You can go straight for treatment. But you can do investigations only to rule out other problems. For instance, if you suspect that this could be pulmonary embolism, you are not so sure between the two because they've got something similar. They all have a cough, they all have difficulties in breathing, they're all desaturating. So how are you going to tell? So there you can insist on certain baselines like a chest X-ray. Do we still remember the signs? Remember the Pala sign, the Hump sign, and all those funny signs that you find on X-ray for pulmonary embolism. You can even go further to do an ECG where you look at features of right ventricular strain, the McGene White sign, S1Q3T3. You can go further to do the D-dimers, which are basically FDPs, fibrinogen degradation products. You can go further and do a ventilation perfusion scan or a CTPA. So again, you don't just do it for the sake of doing. You have to do one test at a time. Because me, if she's a postnatal, I'll just do a D-dimer. If D-dimer is normal, then it's not pulmonary embolism. Coupled with the Wells score or the Geneva or PEC scores. Anyway, I'm not a physician. Now, we go to treatment. Pulmonary embolism. Edema. Management is CPAP. Continuous positive airway pressure. That's the gold standard for managing pulmonary edema. Why? It's because you want a machine that can push air through the airways and then push out the fluid, so that the fluids can get into the blood vessels which are connecting the right side of the heart to the left. That's all, so that they come out. There is another type of positive airway pressure known as a BiPAP. BiPAP means bi-level positive airway pressure. I feel it's even more superior in my opinion, because the pressure going in and the pressure going out are different levels. So those are what you should think of. But you know, all along we have been so used to using furosemide only. Yes. But yes, of course, a diuretic will help. And if you are going to use furosemide, you are going to use very high doses, like up to 120 milligram IV start, then maintain at 60 or 40 milligram BD or TDS. Very high dose. But again, remember, we are giving furosemide on a risk-benefit scale, because giving a diuretic in the wake of a constricted vascular space can do more harm than good. But we know that what is more life-threatening is a pulmonary edema. The next thing is you need to give a drug called morphine. We all know morphine. Morphine at a low dose, like 2.5 milligram, once, twice, or according to response, will help in terms of reducing the anxiousness of the patient. Because somebody with pulmonary edema will feel like they are being suffocated, so they will be anxious, they will be restless. So you can use morphine, and morphine will help with dilatation at some level of vessels. Then, if your last option is to use a drug known as the nitroglycerin. Nitroglycerin is a drug which I'm sure we have used in managing STEMI or non-STEMI, acute coronary syndrome, or those type of angina thing, pectoris, and so on. So that also is an important drug you need to add to your cocktail of drug. In fact, if you have nitroglycerin, I would not even give morphine. But if you want, you can use both. It's up to you. Now, away from those drugs, we need to finally think of covering with an antibiotic. Not because an antibiotic will help treat the pulmonary edema, but it will be a good cocktail. Why am I calling it a cocktail? Because you would have given, you are really thinking, is it pulmonary embolism? Is it pulmonary edema? Is it severe atypical pneumonia? Right? Or at least these three are common. So an antibiotic will go for pneumonia. Then the furosemide and whatever you are doing is going for pulmonary edema. And then Plexane, which is enoxaparin or low molecular weight heparin, is going for pulmonary embolism. So like if you give that, at least, but I'm not encouraging you to be guessing. You need to know what you're dealing with. But while you are working out, you can cover the three lines and not know which one will improve the patient's outcome. Okay, now we all know that there are other options when pulmonary edema becomes nasty. And there are options like what is called ECMO, which is extracorporeal membrane oxygenation. You can read around it. I think that's all. The other complications of eclampsia, like liver capsular rupture, I talked about it in the last lecture. Suspected by severe epigastric pain or right hypochondriac pain or tenderness. Suspected by jaundiced mother, by HELP syndrome on the full blood count and liver enzymes. And when you see worsening anemia, acute abdomen, suspect liver capsular rupture. In that case, when you go to theater, do a midline incision as opposed to a phalansteal or jaw coin incision. And obviously, you need to involve surgeons like Dr. Silf, because he's a surgeon. Oh, can you come over? We have a liver capsular rupture. Then you come there and we'll tell you what to do. I don't know what the general surgeons do in such cases. Of course, the most crude thing is to pack, because you can't put sutures on the liver. Do you think the liver will hold? A liver is a very soft tissue, but we use what are called blunt needles. Blunt needles with a box symbol, not like those for reverse cutting or for round body. Yeah, but of course, you don't necessarily need to suture anything, because what has happened is that the Gleason's capsule has detached from the liver first. The liver is not the one with the problem, it's the Gleason's. Then when the Gleason's detaches, blood will sit in between the capsule and the liver. Then later on, the capsule will rupture itself, and blood will now trickle into the peritoneal cavity. So the best would be to involve an interventional radiologist. Like Dr. Simcoe wants to become an interventional radiologist. So he will be able to know which blood vessels are supplying. Do you still remember the blood vessels for the liver? The common hepatic artery gives off the hepatic artery proper, which now gives off the right gastric artery and the right and left hepatic arteries. Okay, so you need now, they will be able to target those blood vessels and look at which lobe of the liver is affected and block the blood supply there. So those are some of the other options you can use. Okay, and then I will not talk much about HELP syndrome. We know that HELP syndrome treatment is just delivery, but we know there is role for dexamethasone in regenerating the platelets in HELP syndrome. Abruptio placenta, I won't talk about it because we talked it under antepartum hemorrhage. DIC, I think we talked about it to some extent, but we said DIC can be predicted by doing serum fibrinogen. Then you need to give blood products which are rich in clotting factors. Which are those? Fresh frozen plasma. You can consider platelet concentrates. You can consider what are known as cryoprecipitates. And I talked about prothrombin complexes and also factor 7 recombinant concentrates. So there are those things that target the clotting factors and you need to give. Otherwise, DIC is a nasty situation, like I tell you, especially if it happens to you on the table. And sometimes we know that some people say there's nothing you can do in DIC, but don't give up. Remove that uterus, reperitonize, meaning close the peritoneal spaces, because what upsets DIC are two things. One is prolonged bleeding. And I don't know if I talked about it in PPH. My biggest worry in PPH is prolonged bleeding. So resuscitation time should be reduced to about 30 minutes. And you should be in theater for not more than 1 hour. You get the point? Because just that bleeding where somebody puts a cotton, no, let us observe if the bleeding will stop. Comes back, changes puts another one. Yes, the patient won't go in shock, but the fact that you've bled over a period of time, you are inviting DIC closer. And by the time you go to theater, everything you'll be cutting, suturing will be bleeding at the points. Next, blood in the urine, blood in the eyes, blood everywhere. So, to avoid that, when you're on the table, I'm just digressing a bit, remove the uterus, do a reperitonization, complete reperitonization, leave some warm saline there, put a drain, quickly close, and make sure I close all the spaces and close by interrupted mattress on the skin. Then start pursuing blood products, TXA, and everything else. And warn your colleagues to say, should you see blood in the drain, don't take back the patient. Imagine if my senior like Dr. Mandama Jr. did a Caesar, can I even go there to say, let me go in again? But you see, because of lack of communication, the other people who come on call, they will just say, this patient is bleeding, look, this is even full, it's now 500 mils. Then when they go back the second time, unfortunately the patient won't come out of the table. Okay, so we communicate to say, this is a DIC, So let's not worry about the blood. If she loses more blood, give more blood. But let's continue pursuing fresh blood or blood products which are rich in clotting factors. Then you can hopefully offset the DIC process. Which other one have I not talked about? Liver failure, and then, and of course the other complications which I've already talked about. So that was where I end with talking about the complications of pre-eclampsia. What is important is whenever you are seeing a patient with pre-eclampsia, those complications will run in your head. Are they happening? Have they happened? How do I look for them and how do I treat them? But if you're just looking at blood pressure and protein, headache, epigastric pain, and reflexes, you might actually miss the bigger picture, which are those series of complications. So every time you are doing a white grounds, those are the things you are looking for. And that's why the first principle in managing pre-eclampsia was rule out complications. Because you want to know what is our baseline. So you don't just do investigations once. After 3 days, repeat again. What if the ALT, which was 36, has now become 120? After 3 days, it has gone to... Then there's worsening condition. So in the face of worsening maternal or fetal condition, where now the liquor starts going down, where this is happening. So it's a day-by-day decision if you are managing pre-eclampsia expectantly, because your decision will be based on the patient's outcome, clinically or by investigations. Okay, stop.